This is this year's mental health diagnosis or diagnostic series. My name's Kyle. I'm a social worker here at ASAP Clinic, and I'm one of the coordinators for the series. This is a 55-minute Zoom didactic. It's free. It's presented by experts in the areas that are covered, and we're just going to provide fundamental clinical education on these topics. Hopefully, you'll be inspired to go out and learn more and do some deeper study. And this is to help folks who are working with individuals with mental health diagnoses. And today, you can go to oh, we're not on the slideshow yet. Okay, I have a prompt here to go to the next slide. The way this is set up, you actually will have your camera and your microphone active. Please pop any questions into the chat, or if you like, you can wait till the end and we'll have a little bit of time for you to ask those questions as well. Folks who are here for CEUs, you're going to get an email from Aaron Watts, our other coordinator, and it's going to have a link to a survey. Fill out that survey, and then you'll get your CEU certificate. We do need you to be here for the majority of this presentation in order to get credit for coming today. And please make sure you're using your own Zoom link that was emailed to you. That's how we know that you're here. Nurses who are here for your credit as well, there's going to have a QR link on the screen at the very end. So scan that, fill out that survey, and then you'll get credit for being here today. Thank you for starting the slideshow, Dr. Lindsay. So today we have Dr. Lindsay here to present on the history of treatment for mental health and substance use disorders.
Great. Am I ready to get started, Kyle? Awesome. Thank you so much for that introduction. Yeah, so welcome everybody. Happy to be the first presenter to kick off another didactic series. We're very, very proud of this particular offering and really excited to have all of you either joining us again or joining us for the first time. So I skipped over my slide that says I have nothing to disclose, no financial arrangement related to anything I'm going to present today. And like Kyle said, I am going to talk about a very brief overview of the history and treatment of both mental health and substance use disorders. And I think it's useful to tie these two together because we have historically sort of artificially separated those. And so I hope that by the end of this hour, you will really understand how they hang together. So I'll be going over the history of and defining what is mental illness and substance use disorder, as well as some of the underpinnings for these different types of conditions. And then I'll be wrapping up with some of the best practice recommendations for how we would approach treating the comorbid presentation of substance use and mental illness, or either as a standalone. And we'll introduce what are some of the recommended models, one of which is called the recovery-oriented systems of care. So I'll be going over those pieces. So first thing that I want to talk about is let's do some defining. So before we talk about pathology or mental illness, let's define what mental health is in and of itself, because sometimes we throw these words around, and it's nice to have a clean definition of what we're talking about. So mental health is more than just the absence of disease or the lack of mental illness. It also means really the entire spectrum of how an individual interacts, both their qualities, their characteristics, whether that's inherited or acquired through learning, but everything that comes together in the individual to allow them to achieve and sustain emotional, psychological, and social well-being. So it's really how are they functioning in general across these different domains. So that also includes the ability to handle stress effectively, relate to others, and make choices. Again, thinking that that's on a continuum. So we all have good days and bad days, but there isn't noted dysfunction or impairment in their ability to do those things. Many factors contribute to being able to attain and sustain mental health, which include biological factors, so the genes that we're born with, how things may be affecting our biology, our brain chemistry, our brain development, life experiences. Obviously, trauma has a huge impact, but so do things like positive stress or even experiences of traumas when recovered effectively, how much resiliency a person could have or lack of resiliency may influence their ability to attain and maintain mental health. And then lifestyle and life circumstances. So we recognize that people don't live in vacuums, that there are many contextual factors that influence both how they're maintaining health globally, generally, how much social support or availability to social support they have, and then are they able to participate in things that bring them meaning and purpose, such as work, close connections and relationships, opportunities for leisure or other pursuits, right? So before we move into talking about mental illness, which I know is the focus of our discussion today, it's important that we put a couple caveats into place. So before I define that, I want to just throw in there this concept that how we define what is normal versus what is abnormal, which would be any kind of disease, pathology, condition, right? What we are considering healthy versus unhealthy depends on a couple concepts. The first concept is cultural relativism, which in brief is recognizing that anything that's labeled as abnormal, unhealthy, symptomatic, dysfunctional, those things are bound by the culture or the context in which the individual exists. So we define what meets normal or abnormal as a society. And that's important to recognize that a particular behavior isn't inherently abnormal. It could be what we would consider baseline or normative in one context, in one society, in one system, and in another very, very abnormal or something that would be that we would label as problematic or symptomatic. So recognizing that even as we define mental illness, there is a cultural component, contextual component that we can't eliminate, that we define it as a society. It's not purely objective. The other piece that is really important, and what I think is our baseline assumption that we want to always go to first, before we look at any of the diagnosis pieces, we need to identify, is there functional impairment? Because if I open up the DSM and flip to any page, I promise you, I'm going to meet a handful of those symptoms, because that they can describe anyone in any given context or situation. But we want to look at those symptoms within the whole person, within their context, and say, is that symptom or set of symptoms or diagnosis actually causing impairment in their ability to function across the various life domains? Because if there is no functional impairment, then even though it may be strange or odd, or it may actually be abnormal within the culture, it's not going to rise to the level of what we would label illness or disorder. So that's just really important. And within functional impairment, we have to understand that there's both the subjective rating or evaluation or discomfort. So that's what the patient reports as impairing in their life. But there is also the objective impairment. And so we can define that as the symptoms, which is what the patient feels or reports, or what they're coming to say, this is problematic for me, versus the signs, which is what we might observe as an outside observer or a family member or significant other may report. So, so we want to be looking at both when making that determination, is there functional impairment? And then the last component here, when we're looking to define, is this mental illness, is maladaptiveness, which goes hand in hand with the two above, functional impairment and cultural relativism, which is really saying that in this context, so including their cultural norms, that particular symptom or behavior across whatever domain it is resulting in an inability to adapt. Right. So a lot of symptoms that we see that present early in a condition, PTSD is a good example, major depressive disorder is a good example. We see those symptoms come online as a natural response to, if it's PTSD, the trauma response, or with depression, it could be various contextual social factors that cause those symptoms to come online so that individual can get certain needs met. Now, if those needs don't get met, and the symptoms stay on, that's when we start to see a pattern of their inability to adapt to that component, which then results in the disorder. So we could spend all day talking about just these three things, but I think it's important to ground us that these have to be considered before we move into determining, is this truly a mental illness or not? Okay. That being said, now let's define two more things. So sometimes we flip these terms, mental health condition and mental illness. So a mental health condition really refers to any mental illness. So it's the big catch-all umbrella that would cover the behavioral, emotional disorders, whatever we may diagnose. So here's some examples. That's versus a serious mental illness, or SMI, which is another term. That's that on that continuum is meaning, again, any mental illness that results in substantial impairment. So it substantially interferes or limits one or more major life activities. So they have the diagnosis, but it's on the severe end of the continuum. So you can see a mental health condition would be post-traumatic stress disorder or opiate use disorder mild, versus a serious mental illness could be post-traumatic stress disorder or opiate use disorder severe. So that's really how we delineate. There isn't a specific set of diagnoses that qualify them to be one or the other. It has to do with the acuity and the severity of the condition. The other thing I want to point out, and this is where we're going to start to merge our two topics today, that all substance use disorders are mental health conditions or mental illnesses. They can also qualify as any SMI depending on their severity. So we don't want to separate substance use disorder out into its own category. And in fact, science is starting to recognize that our historical separation between, if you have a mental health condition or a mental illness, you go to your community health clinic, you go to your outpatient therapist to get those needs met. If you have a substance use disorder, you need to go to a specialty substance use program. That those aren't necessarily the right ways to separate things. That people with a substance use disorder, the majority have an underlying mental health condition in addition to that substance use disorder. But the substance use disorder, even if it's a standalone, even if it's primary, we would still want to treat with the same holistic approaches that we would any mental health condition. So to really start to think about substance use disorders fall under the umbrella of mental health conditions, under the umbrella of mental illnesses. They are not a separate category. They're just a separate sort of delineation within the overall big picture. So when I'm going to be talking about the rest of the talk, whether I'm talking about the history of how we have treated mental illness in the United States, I'll have a separate carve out for substance use just to talk about the additional components of stigma with that subset of conditions. But I'm really talking about all of it wrapped into one because they really do fall together. So in a nutshell, to go over how have we looked at these conditions as a country. So just focusing on the United States, I'm not going to talk about globally. We really started to recognize and develop means for categorizing and treating mental illnesses, starting in the 18th century and moving through the 19th century, where we still have impact some of those cultural pieces today. Of course, we have been diagnosing these things for a very long time. We've been aware of them for a very long time, but it really became part of the medical industry. It became something that we viewed as an illness from that perspective, starting in the 18th and 19th centuries. Unfortunately, this category of conditions has been very much stigmatized and marginalized and viewed it from an overly negative perspective, that mental health care in general, or the treatment of patients that were deemed as mentally ill, were really viewed as potentially contagious, and that the goal was to remove them from society. And that's where we got a lot of the sort of inpatient hospital programs that some of which are still in today, but that sort of institutionalization, they need to be removed from their families, removed from their communities, and even certain substance use disorders, they would remove them and put them on farms or ranches, sometimes in different states from where their families or their supports were. And you can see how that would be potentially problematic when we start to look at, what do people really need to recover from these conditions? Most of the time, it's not removal from society or supports. So this is where a lot of the institutionalization really started to ramp up, particularly in the 19th century. Unfortunately, we also started to apply a lot of really bad practices to this population. Eugenics was one, which was endorsed by the Nazis, which we, have all kinds of atrocities associated with it. Forced sterilization. I think close to 100,000 people in the United States had forced sterilization at some point as part of their institutional commitment. Lobotomies were another one. These were ways that we tried to medicalize and I think really disproportionately target populations that were more vulnerable. And so looking back at our history now, not only did these individuals have mental illness or even severe mental illness, but not looking at that cultural contextual piece and understanding the impact of racism, marginalization, poverty, those types of things. We really were targeting immigrants, people of color, people who were of lower socioeconomic status. If they were unmarried, they were much more likely to be institutionalized, and anyone with what we now define as a developmental disorder, intellectual disorder. So, so this is very, very problematic when we think about how we have historically treated individuals with these kinds of conditions. When the 20th century came along, that's when we started to see a shift towards let's have less institutionalization. Really, even though we still have some of these more invasive procedures like electroconvulsive therapy, we no longer do any kind of forced sterilization or lobotomies. And so in the 20th century, we started to see a move towards how do we actually look at other components of recovery, so more of a holistic approach. And that's when you started to see sort of a wellness shift and adding things like exercise and nutrition, medication management. We also saw a rise, particularly in the second half of the 20th century, starting in like the 1930s to the 1980s, an increase in how people could access services freely in the community or through religious organizations. So this is where 12-step was developed and really became more disseminated. And then we saw a self-help programs come about. So people could actually start to educate and get help themselves through books or different programs that they didn't have to go to the hospital to get it. And we saw again that focus on wellness, so shifting away from they're sick and broken and will be this way forever, so we need to remove them from society, to how do we help them connect with society and community and look at things that they may need to access things that are going to help them become healthier. And so looking at things like medication and diet, nutrition, sleep, those different components started to come online. Unfortunately, there was still a large amount of experimentation that occurred during the 20th century, and a number of things, lessons learned through science and how we need to protect this population of people. Now, shifting to substance use disorder and how we have treated that specifically. So again, as a subset of mental health conditions, mental illness, substance abuse misuse has been the most stigmatized of people with mental illness. We have, starting in about the 1800s, 1900s, criminalized addictive behavior. So rather than saying this is an individual who has dependency, who is engaging in behaviors because of that dependency, so we need to give them treatment, we've pursued mass incarceration. And there have been multiple social movements that have shifted away from treatment and more towards criminalizing those behaviors. We've also viewed addiction as a moral problem or failing. And so having concepts that really have no scientific backing like addictive personality, or really focusing on it's just a lack of willpower, they must have weak character, that's why they can't stop or quit. There's very little evidence to support any of that focus with understanding what is addiction. So that has been problematic and resulted in a lot more sort of marginalization of people with addiction issues specifically. In the 20th century, later half of the 20th century, earlier part of the 21st century, we really started to view it as a disease. But that isn't the whole story, because addiction, like mental illness, affects all areas of a person's life and isn't just a cause and effect relationship like something like cancer or diabetes. It's more complicated than that. And so where we are now at this point in time is recognizing that addiction is a complex, multifaceted condition which requires assessment and intervention of psychological, physiological, social, and environmental components. So that's what we're going to talk about. Another piece of history that's important to understand with treating substance use disorders specifically is the difference between the abstinence model, which again arose in the second part of the middle to later part of the 20th century, which really assumes that abstinence is the best, most effective, and only way to treat addiction. So AA, 12-step models, the Minnesota model, which was widely disseminated within hospital settings by the Betty Ford Center, those things adhere to the abstinence model. And then later in the later part of the 20th century to now, we have the harm reduction approach, which is placing priority on how do we reduce harm across all the domains that this individual may be experiencing potential harm or risk. And rather than focusing on they must be ready for treatment, they must be in treatment, or they must be motivated to take advantage of treatment, that we're helping people to use safely, to look at ways that they can decrease their use, or they can use replacements for use until they can build the skills to maintain their recovery goals. So it assumes that people can treat their substance use gradually, that abstinence isn't necessarily the only option. For many people, it may not be the best option, and that people can access various levels of treatment. It doesn't just have to be intensive, focused substance use treatment. So why is this history important? It's important because when we're talking about this class of conditions, mental illness and substance use disorders, we recognize that a huge piece that impacts individuals' ability to access care and sustain in care is impacted by implicit or social bias. And that's that stigma piece. And it has a huge impact on how people will come to care. It has a huge impact on how we treat them when they come to care, and the different treatment perspectives that will be most beneficial for them. So let's look at some data. This classification of conditions is very common. In fact, the CDC said that major depression is one of our most concerning conditions globally. So we recognize that in the United States, on the last time the CDC pulled data, or the National Institutes of Mental Health in 2021 found that 57.8 million adults report experiencing what would qualify as a mental health condition, mental illness at some point during that year. So that's 22% of the United States population. So 1 in 5 Americans are living with a mental health condition, and as many as 1 in 25 with a serious mental illness. So this is an extremely common thing. So here are statistics showing you the breakdown of that large population. And AMI would be any mental illness versus SMI would be the serious mental illness versus substance use. So showing you there is tremendous overlap between these two, both substance use and any mental illness or serious mental illness. And these are large numbers of our population. So of course, this is going to affect huge swaths of society in general. So we really need to be thoughtful how we think about these conditions, how we diagnose them, and how we view them as chronic conditions that require the kind of concerted care that things like diabetes or cancer or even high blood pressure get, right? So another thing to keep in mind is even if we're not looking at the mental health condition, there are many downstream effects connected to it. So 70% of those diagnosed with a mental health condition are going to experience a pretty serious medical comorbid illness like obesity, diabetes, various rates of cancer. So we know that we may be treating them for a medical reason, but the underlying thing is actually a mental health condition. So we also know that these two things are highly comorbid. So if we put the two together, we're talking approximately 7.7 million adults in the US are affected by one or both of these conditions, and that there's tremendous overlap between the two. So there's impact on how this affects our global economy, how it affects our United States, our local community. A lot of impact in terms of utilization of emergency resources, where people, and I'm going to talk about how people access care because of the stigma, because of the difficulty addressing these conditions early from a prevention standpoint. Many people end up accessing care when they're more acute, when it's already more severe, and so they're utilizing more resources at that juncture. So they're interacting with the care community or the continuum of care at points of crisis. And so I'm going to show you a couple models about how we really want to think about stabilizing without having to interact at those points of crisis. We also know it very much impacts just general emotional health and child well-being. So, and anywhere from 15 to 23% of children live with a parent with one of these conditions. And so that's going to result in how that affects the next generation, or how that affects the health and well-being of that family. And then we know that individuals with these conditions are much more vulnerable and much more at risk to any kind of chronic disease, and definitely to that vulnerability of, if I have a substance use disorder, I may end up with a mental illness, and vice versa. So just a couple myths to talk about this. Once you're diagnosed with a mental health condition, you'll never recover. This is a common myth that many people in society may have. And I think that it's important that as mental health professionals, we're always working to address some of these and say, just like any other illness, diabetes, asthma, mental health conditions can absolutely be successfully identified, treated, and managed. And that recovery is not just the absence of symptoms. Recovery is the process of helping people connect to the things that allow them to live a meaningful life. So that means connection to work, to participation in their community, to close connection with the supports in their life. People with mental health conditions aren't productive employees and can't handle the stress of a job. So this idea that if I have a mental illness, I may need to be on disability or some form of supported employment for the rest of my life. And we know that when people receive proper treatment, their symptoms can absolutely be managed, especially from a chronic care perspective, again, just like diabetes or asthma. And so they can definitely access a healthy vocational life that they can attain and maintain successful employment. So that is definitely a myth. The next myth, people with serious mental illness are violent and unstable. And I think when we think about, SMI, we think about things like schizophrenia or bipolar. And it's important to understand that a very small percentage of violent acts or violent crime is attributed to individuals with SMI. That in fact, we know that they are much more likely to be victims of these kinds of things because they're vulnerable, because there aren't social supports necessarily to assist them, much more likely to be unhoused, much more likely to be traumatized or re-traumatized than the general population. They are more likely to be the victim than the perpetrator. That this type of violence tends to be more associated with issues related to society than the SMI or the individuals with SMI. Okay, so that's kind of our overview of history. Now let's go into understanding conceptually what's behind these conditions, what may be causing them. So I want to talk about substance use disorders first, and I like to start this conversation with just a thought experiment. So I'm going to ask you for just a few minutes to think about, how do you handle stress? or distress. When you have a bad day, bad week, bad month, whatever that looks like for you, feeling overwhelmed, how do you manage that? Right? And some people may be thinking, well, I spend time with my loved ones, or I call my friends. I maybe have a glass of wine when I get home. I maybe take a nice long bath, or I binge some shows on Netflix, whatever that might be, right? On that continuum from healthy to maybe not so healthy, but we all have ways that we handle stress. So I want you to connect with that for yourself. What does that look like for you, right? And now I want to ask you these questions. What if someone told you, just stop doing that thing? Or what if they actually took it away from you? The one thing that made you feel better. They said, nope, you can't do that anymore. Or what if you were actually put in jail for doing that thing that helped you manage how difficult life was, whatever painful emotion you might be experiencing, family or work stress? Or what if you felt like a bad or broken person for doing that one thing that gave you comfort, made you feel less lonely, made you have less anxiety, sadness? It'd be pretty awful to imagine if that way that you dealt with the difficulties that life brings, if you were to be punished, made to feel bad for it, broken for it, or if you were to be told, you just need to stop that. It would be very hard to engage that way. So recognize that people with a substance use disorder are trying to meet understandable basic needs. They are trying to manage the difficulties that life brings their way. Is using substances to excess the healthiest way to do that? Absolutely not. But we recognize it is a comfort, it is a relationship, and it is something that has become habitual to the degree where they form dependence. And so when we look at it from the perspective of they need to just stop, or there's something wrong with them, that may not be the correct perspective. So let's talk about, why do people use drugs? And there are many reasons why, but in general, we could break it down into a couple different categories. The first one is to feel better. So this is when you're suffering from something. So whatever that might be, mental health or mental illness related symptoms, chronic stress, trauma exposure, discord in your family system, whatever that might be, like impacts of poverty, or other social determinants that are not within your control. That's going to bring across a lot of difficulties psychologically, emotionally. And so people will oftentimes turn to drugs to lessen those feelings of stress or distress, to have a relief valve, right? So that's understandable. So we know that stress is one of the main things that leads to beginning to use any drug whatsoever and continuing to use that. And we also know that it's one of the #1 contributors to relapse in people that have developed other means of coping. And that's called the coping mechanism theory of use. And I'm going to show you a graphic about that in a moment. The other reason that people will use drugs is to just feel good, right? So even if I'm not trying to offset negative feelings or manage stress that may be happening, drugs feel good. They create a euphoria, no matter which drug it is, or it wouldn't be a drug of abuse. And so people will oftentimes like that feeling and want to engage with that, right? There's a reason why we drink coffee in the morning, and why alcohol is a socially condoned substance, is because these things feel good, right? As a society, we like to engage with that. So recognizing that people may choose a specific drug because they're seeking that initial euphoria, but they're also seeking some of the secondary gains. So for example, cocaine has a link where you feel energized, so increased energy, self-confidence, a sense of being empowered. Those are really positive things that people may choose a stimulant in order to feel, versus opiates has the same kind of initial euphoria that cocaine has, but it's followed by relaxation or feelings of satiation or pain relief. And so people may choose that class of drugs because they're trying to get those feelings. The other thing is people may choose to engage with drug use to do better. So this is where I may start or maintain using a substance because I want to chemically enhance something, whether that's cognitive or athletic, And that this is where a lot of initial experimentation may come from. So we think about why people may start to overuse a prescription drug, or they may use things like anabolic steroids. And then lastly, as humans, we're curious, and we, and particularly in adolescence, are very vulnerable to the influence of others, but throughout our whole life, we're vulnerable to the influence of others. And so we may just be exposed to it. If it's in our community, our family system, our peer group, we may use a drug because of that curiosity. And then there could be other downstream effects related to it. So these are all understandable things why people start using drugs in the first place. Now, if we focus on just the first one, which tends to be the one most predominantly linked to what's later a substance use disorder, it's this feel better component, which is called the coping mechanism theory. So that's essentially where something is happening outside the system, which causes tremendous negative emotion, anxiety, sadness, grief, whatever, fear, whatever that may be, tremendous negative emotion. There's tension to eliminate that, to try to control that negative emotion. You use a drug to accomplish that means, but then and so that tension is relieved and that negative emotion is relieved, so you achieve temporary relief. But then as soon as the drug is out of your system, there's a return of both of those things. So it's highly reinforcing for people to then do what? Take more drugs, right? To re-engage in that cycle. And if you do this enough times, with enough intensity, with enough frequency, you will develop a dependence, both physiologically and psychologically, on that drug. So this can happen to any human, to any brain. We are highly susceptible to that particular concept. So what's going on neurologically? Let's move into that next. So quick pop quiz. What do you think is the primary brain structures involved in addiction? And feel free to chat in if you know. Take a guess. Limbic system, great guess. Amygdala, great guess. Emotion center, yep, you guys are all on the right track. So you're definitely in the ballpark. The two primary systems, which we're going to identify, is the prefrontal cortex, and what people were saying is the emotion center. The limbic is the nucleus accumbens, and the ventral tegmental, or the VTA, which actually sit in that limbic center of the brain. So these two parts of the brain, the frontal cortex and the VTA, work together for these two different pathways. One's a dopaminergic pathway, and the other one's a serotonin pathway. And you can see the functions listed at the bottom of this graphic are huge, right? These two pathways control a ton. Not just our reward or our motivation piece, which we often think about associated, or the pleasure component that is associated with substance use, but it also controls things like compulsion and perseveration, our mood regulation, memory processing. So if you think about it as these two systems work like a light switch, one's a stop system and one's a go system. Our frontal cortex is our stop system, which helps us to think through, which helps us to make long-term decisions, which helps us to understand the consequences of any particular choice, delay gratification, regulate mood. All of those things are controlled by that system, versus the limbic system, the lizard part of the brain where the VTA sits. That part is our go system, which is like, get more of that, do more of that. You need relief. My brain is on fire. And they when one is on, the other is off. And so recognizing that this is particularly important with how people, when they use substances early, and they don't have a fully developed frontal cortex, which doesn't happen until we're about 25, 27, they're already working with a overly active go system and a not very active stop system. But then as we use a substance of abuse over time, that actually starts to erode. And so you can see functional structural changes in a person's brain. You also see that over time, because that dopaminergic system is being hijacked, that the ability to experience pleasure, the ability to experience reward through natural activities, that goes away. So on the drug abuser side of this graphic, you're actually seeing less activity in the part of the brain that would experience pleasure in general. So what does that mean? That means that the drug becomes the primary source of experiencing relief and pleasure, because other things you don't experience as much. And then this graphic shows you the development of the frontal cortex from age 5 to 20. So you can see that adolescence, childhood are very vulnerable time periods, because the part of your brain that you need to turn off the switch and say, no, I'm not going to choose that, or no, I'm not going to engage in that behavior, is not developed until much later on in life. And if we expose our brain to substances before it's fully developed, then we've already kind of circumvented that natural system. So adolescence is a really significant risk time, recognizing that the majority of people that end up with a substance use disorder, 90% of smokers start before the age of 18, 60% those with THC addiction start before the age of 18, 25% across substances start before the age of 18. And that there is a concept here that whatever we start with, we prime our brain for that drug class. So 90% of those with a stimulant use disorder, whether it's cocaine or methamphetamine, were smokers before the age of 18. Because why? Because nicotine is a stimulant. So they primed their brain to be more vulnerable and susceptible to a stimulant addiction. So what about the environment? This is important. We talked about the brain pieces, and it all goes hand in hand. But it's not as simple as we expose our brain to drugs and we become addicted. That there's a lot of contextual factors that go into play, and this is going to be important when we shift into talking about treatment perspectives. So historically, we've done a lot of our studies and what we understand is going on in the brains of people with substance use disorder using animal models. So that's where many of our current ideas on substance use come from. And those studies were originally based on putting an animal like a rat in an isolated cage, so an environmentally restricted cage, and giving them a choice between water and food or the drug. So cocaine-laced water, opiate-laced water, alcohol-laced water, right? And in that setting, they almost always use the substances to excess. They almost always chose the substance over the other, so food or water, which is a signal of dependence. And this would eventually lead to overdose and death, right? So they would eventually develop tolerance, and then they would overuse to the point where they would then die from using that substance. So this is what we tend to think of. I expose my brain to drugs. This is the inevitable thing. Well, later studies have then looked at, this is not how animals live. This is not how humans live. So they took the animal out of the isolated cage where they only have the choice of drug or no drug, and they put them in something called Rat Park, which allowed them to have socialization with other animals, to have sex, to play, multiple food options. They could engage in parenting. And what did they find when they still gave them the choice, the drug-laced option and the alternative? In this setting, the animals rarely use substances. They would still use it on occasion, but they didn't use it to excess, and they never overdosed. So this is important conceptually to understand when we're talking about treating individuals with substance use disorder, that maybe the question we should be asking is not so much about removing or restricting access to the drug, criminalizing or placing consequences associated with the use of the drug, but more focusing on how can we help them change their cage? How can we actually look at the environment in which the individual is using those substances and make it look a lot more like Rat Park, where they have options to engage in meaningful activities, socialization, things that give them value, and then ask them to choose between the two. Because if you think about everyone that's here today, we all have the option of going out and being drunk right now, but we're not. And well, I think most of us are probably not. Most of us are not for reasons that are tied to our values, that are important to us to show up to work, important for us to show up for our families. So we make that different choice, even though we have the option, because our cage looks fundamentally different. So now let's put it all together. So what causes these things? So we know that there's no single factor that leads to individuals developing a mental illness or addiction, but we do know that there's a mix of risk factors and protective factors. And I hope what you're seeing here and noting is that a number of the risk factors, things like lack of parental supervision, availability of drug experimentation, trauma exposure, community poverty, yes, there's a genetic contribution that makes people vulnerable, but a lot of those risk factors are social in nature and oftentimes are outside of the control of the individual. Right? The same thing with the protective factors, right? So these are sort of the cards that people are dealt. And then if we add the genetic piece, if you have the gene or you don't have the gene, then a lot of how people end up developing a mental illness or an addiction is really outside of their personal control. So we recognize that there's a number of things. Yes, we need to repeatedly engage in it. There could be distortions around our use with it, but a lot of what is contributing to this pattern has to do with the disruption of the types of supports and things that help people to maintain mental health, which is what we talked about at the beginning. So we know that it's this confluence of the biological factors, psychological factors, and social factors, which result in psychological disorder. Or the same thing with a substance use disorder, the biological, the environment, then we add the drug into the system or the addictive behavior into the system, which then changes how the brain functions and we get addiction. So we now know that it's a biological, psychological, and social process that results in the development of either of these things. So we need to include that in how we then approach treating this population. So how long do you think we've had mental illness? Throw in some guesses into the chat. Forever. As long as humans have existed. You guys are absolutely right. Actually, since before humans have existed. And this is interesting. This is new science that came out of the Nature of Neuroscience article this year, that they've actually found that genes responsible for mental illness and substance use disorder can be drilled down to this DIG gene, which is in many vertebrates, including mice. But it developed 550 million years ago. So we have had this in our DNA for a very, very long time. What about with substance use or psychoactive substances? How long do you think we've been using this? Okay, same answers. So we only have written history that goes back about 2,000 years, but I'm sure you all are right that as long as there have been access to psychoactive substances, we have been using and abusing them. So it goes all the way back to the earliest written documents, including cave paintings. We see that humans just engage with using substances as part of being human. So we know that that we need to think about these conditions the way we think about any other chronic condition. So looking at those that are able to receive treatment versus those that have unmet need, it's pretty concerning. Whether we're talking about mental illness or serious mental illness, there's still tremendous amounts of people that are unable to access service to get the help they need. Right? So why might that be happening? And the number one reason that almost everything points to is the phenomena of stigma, that mental illness and addiction are the most stigmatized illnesses or conditions that we have, which then places tremendous barrier for people to be able to access care and sustain in care. So because as a society, all that history that we started our conversation with today has placed such a I would say, inaccurate focus on this being character flaws, moral weakness, or issues with the individual, we've really missed the boat with being able to recognize this is part of being human and that it's only a matter of time based on the circumstance or the situation the individual finds themselves in that they may end up with one of these conditions. And so we really have to start to advocate with our medical colleagues, with each other, the community in general, to shift that because there is still a tremendous amount of stigma and bias. I'm going to show you a couple studies specific to medical professionals and how they still view these populations. When the stigma is experienced by the individual, they can develop what's called internalized stigma, which means not only are they experiencing being treated as bad, broken, having poor moral character, but they're also going to start to see themselves that way, believe that about themselves. And that is going to result hands down in poor outcomes for the patient. They are much less likely to seek treatment, to stay in treatment. They are going to have exponential poor outcomes, mental and physical health. They're not going to engage or have access to things that are stabilizing, like employment and housing, or good social support. And then that's going to contribute to this thing called learned helplessness. And learned helplessness is where people, even though they have opportunity, even though they're shown the path to be able to escape the thing that is really hurting them, they will not make that choice because they have learned that they don't have the ability to control it. And so once that sets in, then we really have a lot of work to do to help the individual access the kind of care that they need to achieve recovery. So this is a study that shows you how much that stigma is still very much present. So this asked a group of medical providers, this is a large population, what do you think about people with mental illness? And there was a number of questions, but 21% of these providers said that we should not be giving them health benefits. 59% said that they would oppose or not allow someone with mental illness to marry into their family. And 25% said that they would deny employment. Then they asked them about people with substance use disorder. 22% said that, again, they wouldn't work with someone if they knew that they had a substance use disorder. 54% said that they should be denied housing. 64% said that they should be denied employment. And 90% said that they would not allow them to marry into their family. So if we think about this, like how this impacts both how people with these conditions are treated in society and how they're treated by the people that care for them, that has significant impact, right? So one of the first things that we want to do when we're treating this population is to really be thoughtful about the language that we use to describe them. And I can give a whole lecture on the power of language and how we need to be very careful about the terms that we use, because they can either be healing or they can be very harmful. And that's true both in how we choose to speak about them outside of the patient care setting, but definitely when we're interacting with them. So I just want to give you a quick look at what we're now calling strengths-based language versus deficit-based language. And if you look at this and you say, in my care setting, in my personal practice, I may be using some of these deficit-based terms. Do I have the option of shifting it to one of these strength-based terms? Because this type of, I think, concerted, very intentional shift in the language that we used when we're talking about mental illness, we're talking about substance use disorder, is necessary to start to address some of that stigma. The other large model that I've already mentioned, but that is really important for treating these populations, is recognizing that these are chronic conditions. So this isn't just a one-time thing. Even though we may see it present and treat it as a one-time thing, it could get exacerbated. It could come back online at different points in the future. So using a chronic disease model is really recommended best practice. And what that means is that we're not just focusing on helping people have less symptoms and then we're saying you're done. We're saying our goal is to help you have improved health, wellness, and general quality of life. So sobriety does not equal recovery. It's restoration of meaning and functionality that equals recovery. And so we need to be thinking about that in our treatment approaches. So the current state where we are now that informs best practice for treating both of these conditions means combining all of the different services that are necessary for people to attain that kind of stability. So routinely having a multidisciplinary, multi-system approach, which would include therapy, case management, care navigation, peer support, voc rehab, all of those things to really treat the whole person and help them increase their functioning and awareness. Now, that means that we're addressing it as chronic. We're seeing this as it's the whole person, that yes, we're going to help people achieve more accountability, but no difference than we do with diabetes. We recognize there's choice and lifestyle involved, but there's also pieces that are outside of their control. And so we're going to respect this is where they're at and help to meet them there rather than having certain expectations for them. Also placing an emphasis on what they need, like think about that, the rat park concept, right? What social supports could be most useful for them? How can we help them have better connection whether it's within a group, a community, with their concerned significant others, in their family system, and then being able to navigate those systems. Because traditional access to care for individuals with these conditions tend to look like this, which means that they really wait until their symptoms are pretty high and acute before they enter care. And then as soon as the symptoms drop, we discharge them. So then over time, they end up actually having like this kind of up and down peaks and valleys response, where they're sort of in a chronic stage of relapse and remit. And that can be really corrosive to those social supports that help them to maintain recovery for the long term. So the recommended model is that when we're promoting self-care, when we're promoting recovery, we're looking at things that help them to establish what's going to maintain them from not having those peaks and valleys, to really have continuous treatment response. And that could be various episodes of care. It could be the multiple systems that may be part of those various episodes of care, but just thinking one piece, you're only one piece of the pie, and we have to look at all the pieces of the pie together to help them move into the recovery zone, which is a flattening of that line. So no longer are they engaging with the emergency room or going to the psych emergency or hitting our services in points of crisis. And the approach that supports that the most is what's called the recovery-oriented system of care. And so that looks like this, right? That the individual, the family, the community context in which they live is at the center, and it's surrounded by all of the different recovery, wellness, and health supports. And that we have to help people when they think about their treatment plan, which services or activities are going to hit most of these, because it's not one single piece that's going to get them there. So within this, we're really working with the person to offer a comprehensive menu of those different supports. So I'm going to run through this quickly. Best practices that are recommended is that we use a patient-centered, trauma-informed care. Using that strengths-based language is a big piece of that we offer clinical evaluation and be able to help people not just have a one-size-fits-all, but move up and down a continuum of care. That we think about ongoing treatment planning. So what do you need to do intensively with me? And then how do I step you down to peer support or self-guided support? And then how do you know when you come back? When we need to include specialized care, whether that's, medication replacement or med management or other things that they may need added on. Service coordination or system navigation. If we're doing psychotherapy, are we using an evidence-based approach to that? And then where are we tying in family intervention and community education? And so these are just the recommended evidence-based approaches for psychosocial intervention. And I hope what you're noticing on this page is that we're going to talk about many of these over the course of this didactic series. So we'll be offering separate hours in most of these to help give you a little taste of how each one of these can tie into treating these conditions. So in general, we want to think about meeting them where they are. We can't hold people to certain levels of accountability if they don't have the bottom of the pyramid met, right? So thinking about Maslow's hierarchy and really putting together a recovery plan that addresses all dimensions of wellness: physical health, emotional health, the stability and quality of family and peer relationships, comfort and stability of their living environment, positive community participation. So are they working? Are they volunteering? Are they doing something that's engagement and getting them out of the house that actually results in overall improvement in life, meaning, and purpose? Because that's where recovery lives, whether we're treating a mental illness or substance use disorder or a combination of both. So I know we don't have a lot of time for questions, but what questions come up for folks?